Medical School. Dr. Contreras strives to promote diversity and healthcare among minority patients. She's one of the founder members of the American Heart Association, Hispanic Latino Cardiovascular Collaborative, the Women in Transplant and Mechanical Support, and founding board member of the Equity in Heart Transplant Project, and the current vice president of the Inter-American Society of Cardiology. Her goal is to improve diversity at all levels in the organization. She's determined to achieve equity to eliminate cardiovascular healthcare disparities and improve access to minority patients and women to advanced heart failure therapies, including mechanical heart devices and cardiac transplantation. She's an active clinical investigator in multiple national and international trials, and she's creating novel ways to increase participation of minority patients, and I know investigators as well, in clinical trials. She is a fellow of the American College of Cardiology, Heart Failure Society of America, American Echocardiography, American Heart Association, and International Society of Heart and Lung Transplant, as well as the National Hispanic Medical Association, where she completed a leadership fellowship. Thank you so much for joining us. It's a real pleasure to have you today.
Thank you, Leandro, for the kind invitation, and thank you for the invitation. So, as Leandro said, I'm very involved in disparities for women, for minorities, for people with disabilities, as me having a disability. So I am happy to be here, and I'm gonna try to run through all this because we have been working a lot on this, and happy to answer questions at the end. So, women, we have been talking about women, and we know that both men and women keep dying for cardiovascular disease. And initially, we have seen an improvement, but if you notice the latest data, there is a significant increase in mortality in women, especially in cardiovascular mortality. And when we look specifically at women, when women have actually an event early on in their lives, like we are talking a lot, and you have seen me a lot of maternal health and preeclampsia and eclampsia, when they have an event like infarct or anything that happened earlier, their mortality increase and the acuity of the events increase and their life expectancy decrease significantly. So it's very important that we actually start looking at this a little bit more. And as you guys know, there is a significant increase in maternal mortality to like 40% over the past decade. So it's very important to talk about is sex difference versus sex disparities. We do know that there are biological differences, and we also know that there are disparities. But unfortunately, those two things are combined to produce poor outcomes in women. We know that there are sex differences. The epidemiology is different. Women, we have different risk factors that we talk about it. The pathophysiology is different. And the risk factors of pharmacogenetics and pharmacodynamics could be different. And we're going to talk about that in a moment. But we also know that there is a significant inequality in application of therapies and guidelines in women, as well as access to care in women. And if we talk about minority women, we know that they are not really having the same access. So we know that women are not well studied. We underfeed women. And some physicians, maybe not you guys that are in training, but a lot of physicians in the periphery don't even believe that there is a real difference between men and women. When we actually look at the lifetime risk of heart failure with preserved ejection fraction in patients by sex, we know now that women tend to have more evidence to have HEP-REF than men, and as men have more frequency to have HEP-REF. So we know that HEP-PEP and HEP-REF are equal for both, but when you look at the HEP-PEP population, we know that women are more likely to have HEP-PEP. Why? There are many different factors, and we know that women have atherosclerosis that are a little bit different. We have intimal TIA. We know a lot of dissection happen more in women. We are seeing a more spontaneous dissection even during pregnancy that we are seeing more. We know that the stress cardiomyopathy more frequently in women than in men. And we also know that microvascular dysfunction is a significant contributor to HEP-PEF and to these patients that develop this unrecognized HEP-PEF for a long time, but that we until now that we're doing more studies for microvascular dysfunction, we're finding this out. But let's talk about heart failure. We do know about the progression of heart failure, and we talk about when we think about women at risk of heart failure with the stage A. What is funny, like when you talk about women that are, for example, women that were pregnant early in their 20s or early 30s, and they had significant risk factors like hypertension during pregnancy, preeclampsia, eclampsia, gestational diabetes, that was not considered to be a risk factor before for women because Usually that's considered to happen during pregnancy. They get better. We don't even know, but they may get better, but they never follow up on those symptoms. Now we know that those events that happen early in life of the woman are gonna predict that the woman is gonna have significant cardiovascular risk factors. So I now tell my fellows, when you interview a woman with factors like this, you have to really pinpoint what happened and understand that those things that happen during the pregnancy are going to predict the woman to have significant cardiovascular risk factors and had to be considered as a stage A. Stage B, as you can know, is a structural diseases, but the structural changes that we always look for is valvular disease and hypertrophy of the ventricle, no cardiomyopathy. But there are other diseases that we need to think about that, and I think obesity is one of them, especially in women. So when we look at the registries, the European register, the HEAT registry, I mean, these are all registries, and we look at the data, and 50% of the patients that were in these registries of people hospitalized with heart failure were women. And we really took a long time for us to catch that, more than 3 decades. We know that the incidence increased, and we know the incidence in women triples by the time the woman gets to be 65. We do know that there is this postmenopausal effect that we have talked a lot about it that increase the risk of women. But it's important that to see the incidence will triple in these elderly, older women, and obviously with a lot of unrecognized factors. Okay. The pathophysiology, as we say, different. We know that men tend to have more ischemic cardiomyopathy. We definitely have more data and research and everything that you want in ischemic cardiomyopathy. We have done a lot of advances in the past decade with therapies in ischemic cardiomyopathy. And we know that there's higher mortality. And we know that men also with ischemic cardiomyopathy, as you all know, a man can have an infarct in their 40s or 50s, and he can live another 40, 50 years well. A woman have an infarct in their 40s or 50s, and she really have a significant worse prognosis, lower quality of life. We also know that the non-ischemic cardiomyopathy is cardiomyopathy that develop a little bit later. You have more cardiovascular remodeling. A lot of women that have breast cancer that develop, we know now, cardiomyopathy for chemotherapy are going to have also worse long-term prognosis. On top of that, they also have the prognosis of the cancer. We know that the phenotypes are different. We know that and we have been talking about this for a long time. HFpEF of people with non-ischemic cardiomyopathy, there are many phenotypes. You can have non-ischemic cardiomyopathy and HFpEF or HFrEF. You also have non-ischemic cardiomyopathy that are with a lot of hypertrophy of the ventricle, but you also can have a different kind that is no hypertrophy. So it's a little more difficult to analyze, and we have to talk about the worse vascular stiffness and the systemic inflammation. And a lot of these women that we're seeing with cardiomyopathies, we are looking a lot at the role of inflammation, increased interleukin-6, interleukin-12. We're doing a lot of CRP studies, and as I told Leandro before, we are doing a lot of research and very resident or fellows interested. We are doing a lot of anti-inflammatory research looking at the inflammation, especially in women. So the traditional risk factor I'm not going to go over because we know hypertension, obesity, diabetes, and smoking. We know the risk factors. We know that increase the risk factor for women and men to have cardiovascular disease. We do know that high blood pressure and diabetes increase the risk even more in women versus men. A lot of issues there. There is a recent paper published showing that a lot of women with diabetes 50% of women tend to be less treated and not achieve ideal hemoglobin A1C. So it's a lot to find there. But another thing that is very important is autoimmune disease. I have been working a lot with the women's clinic here, and the amount of undiagnosed autoimmune disease is very high. We do know that a lot of the women that go back COVID has significant incidence of autoimmune disease. We don't know if it's the chicken or the egg. We also know that a lot of post-COVID, long COVID and post-COVID symptoms happen a lot more in women with high inflammatory states. And there are a lot of research going on about the role of inflammation in women. In both men and women, there was significant inflammation during COVID. We also know breast cancer. Unfortunately, breast cancer happen a lot in early stages in the woman's life. And we are looking at the role of this long term because obviously the therapies are getting better, but the old therapies were not as good. But we know that breast cancer changed completely the status of the woman. and the hormonal changes that happen during that. We also know that pregnancy, very important, gestational, as I said, gestational diabetes, preeclampsia and eclampsia, peripartum cardiomyopathy, even the patient recovered. We also know that women are delaying pregnancy until later in life, which also increase the risk of ovarian diseases or complications during pregnancy. We also know that more women are using in vitro fertilization, and we actually are almost getting some data published looking at the role of these heavy hormonal changes of in vitro fertilization. And we know that the later in life the in vitro fertilization happens, and unfortunately happens that way, worsen the cardiovascular disease in women. So it's very important that we actually talk about this. And as we know, a lot of people are it's very difficult to talk about these risk factors in women because many people don't want to talk about these risk factors. So it's important to remember this, and I will encourage people to really deep in the history to actually recognize these risk factors. We also know that the tolerability of medicine is very different in women, and we have very little data in our medicines. We know we have more total body and fat distribution. So we know women have more adiposity, more water distribution. So we know that that's different. We know that we have less hepatic blood flow. We can have more cardiac output rate than the men. We also had increased glomerular filtration rate. We know that these changes can change during pregnancy, and multiple pregnancy can change that. We also have more antibody production when we get pregnant, and the more pregnancy we have more antibodies. That's what increase the risk of acute rejection post-transplant. A lot of these things, we have not really looked at that when we look at new drugs. So when you look at data from clinical trials, in the summary of the data, study 3 randomized trial, and we look at that, you realize that only 23% of women were involved in these trials. And we're talking about not only industry founded, but also government founded, overly most in industry. When you look at for regions, you know, more of the regions are different. And even though we have improved a little bit, it doesn't really change that much. It's very hard to get women into clinical trials. Even if you look at the latest clinical trial with the Entresto, dapagliflozin, and vericiguat, you realize that only 30%, 20 to 30, less than 30% are women in these trials. And these are multinational trials from all over the world, and you realize that you don't really have a lot of women. When we look at the therapies, and we look at backwards and look at the therapy, for example, with sex-specific therapy, there is very data. There is, for example, not even reported data on this. But when you look at the, for example, side effects, the angioedema and the dry cough is more frequent in women. And we don't really know what that is because nobody have really explored that. When we look at ARNI, same thing, only in the eye preserve, as we know, more women have HPV. We do know that there is a benefit in ARNI in women more than men at higher EF. And not surprising when we look at the ARNI and we look at the Paragon data, that was also more women because of the HPV. There is a significant sex-independent modifier, and we know that women have better response at higher ejection fraction than men, and men have better response at lower ejection fraction. So we know that there is a difference definitely there in women versus men, and think that we are actually looking at that now. But at blockers, really, we haven't found significant difference between men and women. When we look at the MRS, obviously, there's a lot of controversy with these trials, but only the top cap have a lot of women. We know that there was no sex-related difference. And when you look at the top cap in the Americans, was a significant effect for sex modifier in women for all-cause mortality. We also know that women, both in HPV and HRF, will benefit with MRAs more than men. Men at lower ejection fraction do better, but men that really at higher ejection fraction is a lot of controversial data when you look at the data carefully in top cap. But actually for women, no. We do, as I said, we have more adipose tissue. There's a lot of adipokines and lipokines that actually Dr. Mark have been talking about that. So important data that is had to come out now with the new MRAs, non-steroidal MRAs. AGLT2 inhibitor, our new drug in the market, really had shown similar benefit for both men and women, and not surprising because of the mechanism of action. Interesting for digoxin, when you actually look at the data, is increased mortality for cause mortality in women more than men. and women tend to have more toxic concentrations, probably because smaller women's different kidney depuration for this one. So very important to remember this. So then you look at the data for untreated. I told them that before women don't get significant treatment, especially minority women. It's very hard if you look at the treatment, they're really not much over months. If you look at the data for Dr. Green, looking at the women, also, as I say again, 30% of data coming from women, and this is looking at the follow-up for ARNIs, for ACE inhibitor, and for beta blocker. It's really the minority of women that are in maximal medical therapy. When we look at the data in general, the people that get to the dose, really very few women enroll in this data, only like 7% of them or 8% are MRAs. When he looked at the regression model or what are the factors related to the fact that people are not in good medical therapy at 12 months, they realized that one of the biggest interactions was being a female. When we look at the registries of data with Dr. Lam and Dr. Trump, the perspective of women around the world. What is amazing is not only the women in the clinical trials and in America. You look at the middle around the world, women really receive less medical therapy, less GDMT, less access to care. We know there is a significant income disparity, women versus men around the world. And probably the US is in a better position. As we know, women tend to be older and more comorbidities. So the registry data made you think about like the disadvantage that women have around the world, not only by the risk factor, but also by the fact that they don't get access to care and don't get treatment and don't get well studied. So that I can summarize that at least we had the biological difference and we had these GDMT factors and the clinical trial. But let's talk about device therapies, because as we go talking about now with advanced therapies, let's talk about what happened with devices. Simple thing like remote monitoring, which we know by the fact that women are better. And I need you have patience. You tell a woman to like keep record of the blood pressure or keep record of the weight. She's gonna show up to your office the next day with the whole paper, keeping record of everything. They're far better to communicate that way. With, for example, with cardiomyopathy, we know that cardiomyopathy have decreased hospitalization, had decreased mortality in patients. When we look at the data, how many women? Again, less than 30% of women are involved in this data. Women that could be an easy implant device that can happen in women, it not happen in women. When we look at the post-approval study and see things have changed across the spectrum, only in the people with high ejection fraction, and I think it's because a lot of them have actually pulmonary hypertension and a lot of them are women. But other than that, there is no significant increase. If we look at this meta-analysis, look at every single remote monitoring from the AIC, the EP devices, the CardioMEMS, the Laptop Champion. When you look at the amount of women, it's really painful to see that it's less than 30%, except for a couple of trials that include more people, more women, but it's really not enough women represented in these trials. And we're talking about class 2 to 4 heart failure, people that have AICDs, people that have CRTs, people that are actually sick, but they don't involve these women in these trials. Let's talk about ICD. We know that there is a survival benefit for ICDs is shown in both men and women, but not as clear in women, because when you look at the data, we know that there is an increased incidence in both appropriate and inappropriate shock in women. So we know that the quality of life and the improvement in therapy in women is not as great, and the mortality benefit is not as good because of the complications. We know that there is more acute complication in women when we place AICDs than we don't place them. So when you look at all the data, women only account for, again, less than 30%. Women tend to be older, more comorbidities, more severe heart failure when they come to enrollment. The disparities, they are less likely to receive AICD for primary prevention, looking at the database. Men are more likely to have primary prevention, sorry. There are fewer ICD therapies, and the mortality benefit, and the women is still controversial how much the mortality benefit is there. So important to remember that when you see patients, well, there are a lot of things. Women tend to have non-ischemic cardiomyopathy, so maybe the benefit is not there. When they actually look at data, looking at non-ischemic cardiomyopathy and the burden of scar, even with significant scar burden, non-ischemic cardiomyopathy had less likely to have AICD shocks to prevent mortality. So we still have to look at that, but we still don't have data about that. What about CRT therapies. Again, women account with barely 30% of the population, but it's really an important interaction by sex that wasn't reported. When you look at this therapy from Strauss and Eileen Hirsch, and we look at the people depending on the QRS, the people that really had the maximum benefit for CRT, the QRS more than 150, left on the branch block, we realized that women were less likely to receive therapy, they were more likely to be responders, more likely to have reverse remodeling, and more likely to have more appropriate shocks when they actually have CRT therapy. But they were less likely to actually get CRT therapy. So it's definitely a significant difference in women, probably by the same token, no? There are women that have more dilated cardiomyopathy. Probably they have wide QRS and non-ischemic causes. They're more likely to experience reverse remodeling. You actually can synchronize their heart. Sadly, women are not being offered these devices. Why? Many reasons, but important to see that when you see a patient in your clinic. Cardiac rehab, definitely underutilized in women. Women know very low enrollment in rehab, very adherence in enrollment, is a lot of issues, comorbidities, social support, family that want the woman to go away, a lot of women want to be home, or the women are always the caregivers or the family. Many times they sacrifice their own health to take care of their family or their loved ones. So, but we know that they will benefit to go to therapy. So significant progress with rehab. Implement heart failure, that is this remote study that we're trying to look. Maybe if people don't have to come to the hospital and we can do virtual care, we're gonna do better. Unfortunately, very few women were involved in that study, and very few actually people that didn't speak English and people with another language. So definitely another point of improvement, and we're doing a lot of efforts in making sure that we actually try to include as many women and men in all our clinical trials. To play devil advocate as somebody that done a lot of clinical trials, it takes a lot of more effort and to include a woman in a clinical trial. It takes a lot more convincing, and many times you have to actually bring another family member, because a lot of the older women, they don't understand very well what we're talking about when you talk about a clinical trial, and so it takes more time, education, and you actually will have to bring a family member to the next visit and be more open to explain to them what needs to happen for the patient. So it definitely is an effort to do it, and we actually have to be able to do it. And definitely women, and as I'm gonna show you guys later, are more likely to agree to participate in a trial when it's a woman asking them to participate, and if you actually have coordinator that can relate to the patient in their own language, and obviously the same gender. So in summary, I cannot say this anymore. It's like, it's so, and this editorial, you guys want to read it, is very good, talking about how are all these factors creating significant inequities in women in heart failure. And there are many ways that we can work on this and make an effort to work on this a lot. So let's go now to therapies in shock for women versus men, because I have been a recent data that is important to look at it. So we're gonna start with the registries. So the registries, we know that there have been these big registries. It's very hard to do a lot of research in shock, but we had the registry. But when we look at the registries, even though we know that it's 50% of the patients that come into the hospital that come with heart failure are women, and at least 33 to 45% of the shock patients are women. And the registries only include about 30 or less of women in these registries. Obviously, these are the people that actually were treated for shock as shock and part of the shock team and part of the consider for devices, which is already a bias. When we look at the women that were in these trials, there are higher risk profile. So a lot of time, because of that reason, the device were not offered. They tend to be older. As they are older, tend to have more comorbidities and tend to have higher ejection fraction. Very important. Women can come here and I have actually a woman in my unit right now who is in shock, multiple pressors and impella, and she came with an EF of 40%. So it definitely tend to have higher risk factors and tend to have more comorbidities, more restricted cardiomyopathy. I think this lady have restricted cardiomyopathy more than the EF is high. But they're definitely underrepresented in this trial. A lot of issues. When they look at the approach to this trial for ischemia, they, even though they were in all the trials, there were no significant difference in the application of PCI. They were more likely to undergo PCI if there were significant evidence than otherwise, but they were in women, they were more conservative in surgery. The women that, for example, came with three vessel disease, maybe you could consider to go for surgery, were more likely that the woman was taken for surgery. And they were more likely to have bleeding complications. We know there are more vascular complications. We do know women are smaller person, and a lot of women have smaller blood vessels. And we know that a lot of the devices that we have are very big. And they, in the data, tend to have more vasopedia and tend to be in vasoactive medication for longer, what, as you guys know, will increase the risk of complications. That is from registry data. However, when you actually look at the mortality data in women, when they actually were treated, the mortality in women is not significant difference, except there was in two of the trials, they noted that there was a significant increased mortality at 1 year. But only in one of the trials was really proven, but there was no significant difference. And the women that were treated with interventional devices, they have a similar mortality than men. So even though they may have vascular complications that probably is going to increase their morbidity and mortality and maybe the ICU stay, at the end of the day, they actually have similar mortality. So that make you think a lot about how we're treating women versus men. We definitely need to treat women better with better device design and better hemocompatibility. And we're going to talk about that later. In mechanical support, this is data from Eileen published using the LVEDs, comparing the old versus the new. There was, when she actually looked at every single one of the studies by itself and compare the mortality, the percent of infection, the bleeding, the device malfunction, there were not really significant difference, especially with the devices that we're using right now, the continuous flow. And I put that out there earlier because of this. So this is a very nice group, the cardiogenic shock working group, who are looking at the data of all these persons that were enrolled in this group. And I think we are contributing to the data. I think you must be contributing. When we look at this, it definitely opened up a different kind of worms. When we look at these patients and you look at members of women, you realize that there are two kinds, they divide these shocks into acute MI related shock and heart failure related shock. When you look at the data, women are more likely to present with heart failure related cardiogenic shock than men. That's the first difference. No surprising. If you actually look at our ICUs, it's exactly the same. So women tend to be, and women tend to present to the hospital as a heart failure presentation, de novo heart failure, as cardiogenic shock, 26% in this cohort of patients, and 16 over in their cohort. When you look at, then it's amazing how most of heart failure and de novo presentation more likely in women. Very striking data when you look at that. Then you look and see, okay, what happened to these women and what happened to the mortality? When I go into this. So when women present with the shock, men tend to present more with acute MI shock and tend to present with the highest state of shock when they present. When women present with heart failure shock, they tend to present with higher state of shock than men present with higher state of shock. You do a sky stage. We made you think about, wow, so something is different in these women. And when women present with the acute MI, as they go to the maximum, and they go through, and you look at what is the maximum state of shock that they get with acute MI, the presence were higher, and the same thing when they do with heart failure shock. So in summary, I can say women are very sick and they get very sick fast, so we don't treat them. However, they are less likely to have a SWAN, a PSA catheter. No, it was a lot of controversy, and they're more likely to have devices. Men are more likely to have devices and more likely to have a PCI. And we now know that PAC catheters are something that we need to use in shock. So and that's something that we can change. And there is no contraindication for a small vessel because anybody can actually have a SWAN place. So that's also another thing that made you think about what is happening to us. But I I do think that it's important to see the survival. We know that women have less survival when they go for heart failure related shock. We do know that women tend to have more vascular complications. That's real and it's here. We do know that they have more bleeding requiring surgery. And a lot of limb ischemia we see a lot more in women when you put in pellets and balloons and all this stuff. So definitely women tend to have more vascular complications. So we actually need to think about how we're gonna support women better. And maybe we have to look at different options and maybe consider axillary access earlier in women than in men, but it definitely a lot more vascular complications. And women also have more frailty when they come to be older. When we look at the data in women that require transplant or LVAD, still there are more men undergoing LVAD therapy in both acute MI and heart failure shock than women, which we know that the board will do well with both. And there are more men undergoing transplant, especially with the heart failure related shock, which I think that is a significant bias because a lot of these, and as you know, a lot of our LVADs and transplants are now happening in Intermax 1 to 3, a lot of Intermax 1. So it would be good and to get a more granular data in about what women are not going to advanced therapies or are not having LVAD. You were thinking because women are older, they are not having LVAD. But let's look at and see what the data is. So definitely women have decreased survival and worse cardiogenic shock severity compared to men. That's the first data that we have from this cardiogenic shock working group. And as you know, they are looking at more data going forward, but it's shocking that we actually now have clear data in patients in women versus men. Worse decreased survival and worse severity of shock. When we look at advanced heart failure and we look at the million of people that are going to have heart failure and are going to go into advanced heart failure, I know I'm talking about the minority versus the people that are gonna die. And knowing that if you get advanced heart failure and you get an LVAD or transplant, your survival could go up to 88 to 90%. We early on, a lot of the data, and I know we have a lot of controversy when you look at the data. The reason why a lot of women were not going for LVAD therapy is because there was a lot of considerations about more bleeding, more risk of a stroke. We know that the early LVAD trials show that women have significant more incidence of embolic and ischemic and hemorrhagic stroke. There is a lot of more RV failure. Women tend to have more biventricular dysfunction, so that's something that we have learned. And with the initial devices, they feel that when women have an LVAD, they have lower quality of life. But let's look at the data, and that was data that showed that because of the reason there was a hesitant in having less women refer for this kind of therapies. Obviously, as we talk about, less women enroll in trials, less transplant happening in women, and worse mortality in women. But when you look at this data, look at the source of the data. A lot of the registries, Intermass, NIS, registries, the device in this data are a lot of these devices were the older generation of devices. Again, 70% of these patients were females. So we're talking about a minority of patients that were able to get to this. Obviously, probably were the sickest one. And yeah, there may have been a lot of increased mortality and increased adverse events, but we only have a 20% data and we don't really have sex-specific outcomes that were determined before going to these therapies. So now look at the data that we do have, that is the LVAD, the HeartMate 3 data from the Momentum trial. And there was a very nice paper by Ramu showing obviously still 20% of the patients were women. But when you look at the overall survival, was identical. Actually, you look at it, probably better for women in overall survival in women. Okay, less likely to have ischemic etiology. Actually, there was a little more GI bleed, but nothing that's significant enough. The stroke rate maybe have been bigger. And what we have learned is that some of the LVADs are happening a lot in younger women. A lot of women that have postpartum cardiomyopathy. We do know that peripartum cardiomyopathy can produce hypercoagulability. We do know that we have to be extra careful in anticoagulation in women that have peripartum cardiomyopathy, and as you know, women with low ejection fraction with peripartum cardiomyopathy must be anticoagulated. So we're learning more that younger women may have a different coagulation factors that we have to take a look at it, that we are looking at it. That older women is the opposite. They don't have that, and they have more incidence of bleeding, more right ventricular failure. A lot of the cardiotoxicity patients have significant RV dysfunction. If you look at the cardiotoxicity data, the RV all suffer during these therapies, so we need to be careful in what patients we do. But when you look at the data in male versus female, even though has increased a little bit, we don't really have a significant difference. And when you look at, I think I'm putting different data. This is for transplantation. When you look at the allocation system, there is really a little increase in women, but it really the survival with both men and women is good. I think I missed one. I wanted to go to this before. I want to go back to that one. When we look at the HeartMate3 data to predict who is going to have good survival with the LVED, and you want to look at this data, with all the variables that they have, gender was no characteristics that we predict. So because they found that there was no significant difference in survival. So that's the important thing to remember on that one. Second thing, women are more likely to have recovery and be able to get the LVED explanted. So I wanted to recall that we have a lot of younger women, less than 50, non-ischemic cardiomyopathy, that's 2 years from diagnosis, lower or smaller cavities, or less pulmonary hypertension, and better kidney function. We know that they do better, and women tend to be in this category. So that's why I wanted to go with the LVED. Now I wanted to go to the sex-specific samples in men versus women. It really, we have identical survival. Actually, women tend to if they give women heart into women, we have better survival. And I'm gonna end with this clinical trial, so I don't have to go back to say that the clinical trials are not really representing women. I like this data because basically when we look at the real data versus the people that go in clinical trials, we realize that the real people that will benefit from the trial will be bigger and better. And if we actually enroll the people that benefit, and you look at this is looking at white women versus white men and black women versus white men, black women will have more benefit of the therapy, but they are not enrolled. But when we look at the data, who get enrolled in clinical trials, we know that trials that are led by women tend to have more women and more persons of color. So we do make a big effort in increase that reporting and increase the gender of women and increase women in clinical trials. As I said before, we are working with a lot of the companies in creating pathways to educate women about what a trial means and understanding the difference by race and ethnicity, because women from different ethnicities, and one thing that we have learned is that the ethnicity and the cultural patterns are stronger in women versus men. A lot of time, for example, women from different cultures will not enroll in a clinical trial if they don't have their spouse present. And sometimes we actually have consent forms where the spouse actually consents because she doesn't feel comfortable even signing a consent form without her husband or partner present. So we have to, we're learning more and more about that, and the language of how you communicate with women has to be a little bit different. So in summary, I want to get you, this is one thing that I have been making a lot of my fellows and everybody pay a lot of attention. We're very good with the traditional risk factors. We're very good with high blood pressure, obesity, telling people not to smoke, but we're really bad in really identifying the women-specific risk factors. We need to identify her pregnancy history is very important. We need to talk about if there was an in vitro fertilization. I have patients that have gone for 12, 14 in vitro cycles. I have patients that, and because of that, they probably are going to develop menopause in their 40s. So it's very important that we ask this question because the women that develop menopause in their 40s, the cardiovascular risk factors are significantly higher than the women who develop menopause in their 50s. So I think it's very important that we talk about these factors and demystify that. We talk about depression. We know women suffer more about depression, and we know that and this is a very nice new paper that was published by one of our fellows looking about the different antidepressant and how they don't react as well in women versus men. So very important to look at that. And the autoimmune disease, a lot of lupus, a lot of rheumatoid arthritis, a lot of post-COVID and long COVID. We do have a long COVID clinic here, and we're looking at all those factors, and we have found increasing in endothelial factors and interleukin. So it's very important that we talk about that with our women. And this is a nice paper that we identify all the barriers that we may have, all the barriers that we have for everything from clinical trial, from advanced therapies, from support, and that is what we're trying to put solutions, or how can we offer solutions for women at every level to be able to have hopefully better health. We do have a Latin American source of women. We run the biggest probably Latin American campaign for maternal health with the American Heart Association, trying to look at ways and create registries and access to better health for women across the world and improve their cardiovascular health. So in summary, I don't need to be aware of the cardiovascular factor, and we know that women are a specific population. Women are no little men, and we really need to consider them differently, consider the risk factor differently. We do know that they actually have similar mortality than men. They will do better if we actually treat them better. There is no reason for no offering mechanical support or heart transplant to women. It may take a little bit of tune-up on our part, and important to refer women. And I always make fun because a lot of my Hispanic women, the families always like, oh no, grandma cannot walk because she's older. And they justify a lot of the things because the patient's getting older, and especially for women. I wanted to demystify that because grandma can walk, but we have to understand why she's not walking because that cannot be justifiable. And with our HEPA trial, we see a lot of that. A lot of like women tend to allow the symptoms to happen for longer because they think that it's normal that happen, and that's not normal. And in transplant, we have been learning more about the sensitization. I know a lot of women, especially African American women, tend to have more active rejection, but we have way to treat that. We have way to be able to prepare for that. So there is no indication for women not to have a transplantation. Thank you. Happy to answer any questions.
Thank you very much, Dr. Contreras. That was amazing. It's something that we know, but seeing the data all together is also a little bit astonishing, and we see how much work we have to do. So if you have any questions, please place them in the Q&A. I think as a question, obviously, we know the problem is there, and there are some centers that are creating these specific centers for women's health. Do you think that's a solution, or at least a move towards decreasing these disparities? What are your thoughts in these centers?
Yeah, I think it is definitely a step forward, and it definitely can help. I think a lot of women, especially different ethnicities and people will feel better, more comfortable going to women. Unfortunately, it is very true, and I see now in my clinical trials, a lot of women, the only primary care doctor and the only doctor that provides care is the OBGYN, because a lot of women have very limited access, and the OB person have been the person dealing with them during the pregnancy, and because it's such a relationship that they built, they may don't even have a PCP. I have a lot of women, and I'm working a lot with OB in my clinical trial because I have a lot of women that the primary care doctor is their OB. So we now realize that we had to create that connection. And I don't think it has to be a women centered run by women and be only women, but I think we need to create a connection with those doctors and realize where women are going. So I do think that that's a step to start right direction if you have the right people on board.
Yeah, that sounds great. Yeah, in particular in lipids, I know there's a lot of push to have people to have women screen at the time they're even going to for OBGYN appointments or GYN appointments, because that's a missed opportunity for screening otherwise if not used. I love that concept of referrals from GYN.
Yeah.
So I think we have no questions, but this was wonderful. You're doing amazing work, and I think you're tackling this in all the different components, because it's not the patients, it's how we train people also in diversity. We bring diversity to investigators, like you said, from clinical trials in order to push forward on this. So thank you so much for the lecture, and keep the strong work you're doing.
No, thank you so much for the invitation. Thank you.
Okay, take care. Enjoy the
Thank
weekend.
you.
Bye-bye.
Bye-bye.